Hi, everyone. Happy Wednesday. I think the last video I recorded, it was like 80 degrees in Dallas. Now it is way colder. Even though I spent 30 years of my life in Boston, I totally hate the cold. Anyway, so today I want to talk about protons. I think if you are someone who cares for patients with cancer, you have probably been asked about protons. And I think there is some confusion over what protons are, what they aren't, what data supports them. So I'm going to talk a little bit about that, but then really focus the discussion on how I would approach counseling patients with regards to protons. So let me go ahead and share my slides. Okay, this is proton radiotherapy, my take, and an approach to discussing with patients. So first, what is the rationale for protons? So let's just look at the figure on the left. On the y-axis is radiation dose, and on the x-axis is the penetration depth, or you can think about that as depth in the skin. So you can see right away that protons have this sharp peak, that's known as a Bragg peak, which means that they have a sharper dose fall-off distal to your tumor target, and also less dose proximal to their target too. They're more precise. Note, however, that their potency, and the technical term for that is relative biologic effectiveness, is similar to photons. So they're not more potent than photons. So putting those two concepts together, the benefit would be less dose to normal tissues, leading to potentially less toxicity. So potential scenarios that protons may be most beneficial in would be in pediatrics. We know that younger children are at higher risk of a secondary malignancy. Their growth plates haven't closed. They could stand to benefit more from less dose to normal tissues. In scenarios of re-irradiation where the normal tissues have already seen prior dose, and then potentially in tumors in the brain and spine, which could be next to critical structures such as the optic nerve, the cranial nerves that you really want to avoid. However, there are downsides and limitations of protons as well. The first is cost, and this is variable depending on one's insurance, the institution delivering the treatment, also the clinical scenario, but generally estimated to be about 2 to 3 times that of photons. That's obviously a typo there. The second related to that is that there's limited availability and access to protons. So many places in the US and even more so globally don't have protons. So patients may have to travel very far to receive them. And the third, I'll explain a little bit more. Protons have been around for many decades, but there are still some unknowns with regards to what their actual biologic effect in tissues is. And two examples of that are end of range uncertainty, so that there is some imprecision in exactly where that Bragg peak lands, leading to potential for unintended toxicity if it happens to land in normal tissue. Also, sensitivity to tissue heterogeneity. What does that mean? So when we calculate a radiation plan, we have to take into account if the tumor is in the lungs, if it's in the soft tissue. And proton radiation may be more sensitive to differences in the background tissue. The last 2 points have to do sort of with the logistics of delivery of radiation. So one is that we have to manage motion, particularly intrafraction motion that occurs with breathing and whatnot. And then also we have to verify that the patient is set up appropriately, as similar as possible to during the radiation planning simulation. And those two aspects may be less precise with protons than photons. So those are potential downsides. I just want to point out that the marketing forces for protons are quite strong, and sometimes what's put out there is actually quite misleading. So this is an ad for protons. And if you look at some of the numbers in there that they improve overall survival by 150%, that's just really not supported by data. So definitely understand how, if you're seeing these things, they can be very confusing. So what do the existing data show? So I break it up into 3 categories. The first is dosimetric. So what is dosimetric data? In radiation oncology, it means comparing plans. So if you compare a radiation plan of protons versus photons, protons will always look better on paper. The question is, does that actually translate to better clinical outcomes? The second type is retrospective comparisons. And let someone say that I'm like a hater of protons. This is actually a project I worked on as a resident where we looked at protons versus photons for HCC, and actually found improved overall survival with protons, which we hypothesized was due to less dose to normal liver, leading to decreased rates of liver decompensation. Of course, retrospective comparisons have limitations, and the main one is selection bias. Randomized data provide level 1 evidence, but we acknowledge there are actually few positive randomized trials for protons. The ones I can think of are in CSI, cranial spinal radiation, oropharynx, and esophagus. I'll talk about that one a little bit more, but each has limitations. There are several ongoing radiation trials, randomized control trials of protons. HCC and esophagus are GI ones I can think of through NRG, but for various reasons, accrual has been challenging. So how do I approach discussing with a patient if they ask me, hey, what do you think about protons? And I really approach it through sort of these 3 sections, and I'll use esophagus cancer as an example. So 1, I talk about the dosimetric rationale. So what are the disease-specific potential benefits of protons for your type of cancer? So for an esophagus cancer patient, I would say, well, the rationale for using protons is to decrease radiation to nearby normal tissues. And for an esophagus case, that's the heart and lungs, and also immune cells. We know that excess radiation can cause lymphopenia. So that'd be the first thing I say. Why would we even use protons anyway? Second, I would talk about the existing data. What is the best evidence for protons for your type of cancer? And for esophagus, I would say, I think the best data is a randomized phase 2b trial showing that protons decrease toxicity as compared to photons, mostly in the form of postoperative complications. I would note that there is a larger randomized phase 3 trial that is enrolling that we hope will provide more definitive evidence. And then I would just kind of put those 2 together. So say, putting the rationale and the data together, this would be my thoughts, my recommendation. So I would say, I think for someone with lung or heart comorbids, or we're really worried about post-op surgical complications, potentially if the radiation field is very large, protons may be a reasonable option provided they are accessible, meaning you're not traveling long distances or paying out of pocket, because I don't think necessarily the evidence is there to support those sacrifices quite yet. Okay. So just last slide, closing thoughts on protons. I just want to emphasize that they are one of several tools we have in radiation oncology to make our treatments better, more precise, increase the therapeutic ratio. Other things we have adaptive radiation, we have MR-guided radiation, and then just really the most important thing is judiciously kind of deciding your target volumes. We need better randomized data for protons and other new technologies, and myself and some colleagues made that point a couple years ago in this editorial rewrote. And then just closing, in some cases, protons may be very helpful, potentially. In others, they are not. It may even be detrimental. So you really need to evaluate the potential benefits of protons for each clinical scenario in the context of the available data. That's all I have. Obviously, people may have different thoughts about this issue. I certainly welcome any feedback, and I hope that was helpful.